first person here is Morgan McCluskey, who, after receiving a Bachelor's of Science degree from the University of Puget Sound, came to work for us at Research America. She worked on our global health research advocacy team, but after a year, she was lured away to get her master's in public health at Hopkins, and is working now in Colorado, here in Colorado, and very much, we think, a star of the future. And one of the things that I worry about, and perhaps you all do too, is what's going to happen to the future stars of public health, given that kind of wrench of squeezed resources and lack of attention to the pipeline of our future in terms of leadership, of well-trained, committed, energetic, talented members of the public health community. So we look forward to hearing from you, Morgan. And we miss you, let me just say. So, David Goff, sitting here in the middle, is the Dean of the Colorado School of Public Health. He's about to leave Colorado, however, and go to Washington, not because he's running for Congress and is going to win, although I wish he were, frankly, let me just say, David. But because he's going to take a position as the next director of the National Heart, Lung, Blood Institute at NIH, Division of Cardiovascular Services. And that'll start up just about a month from now. And he has a long background in public health that addresses cardiovascular issues, but serves communities in the process. And before being in Colorado, was the chair of epidemiology and prevention in the Division of Public Health Sciences at Wake Forest. So welcome, David. He's also active, I wanted to add, in the Association of Schools and Programs of Public Health, which just came out with a really first-rate document to be used, hopefully studied and used by the transition team for a new president. And I hope you'll make a few comments about that. It's first-rate. Next to David is Julie Gerberding. Julie is at Merck and Company these days. In fact, since her time as the director of the Centers for Disease Control and Prevention. Julie came to the CDC in the late 90s and was so highly regarded and awarded later for her work, memorably on the anthrax issues after 9/11. And after that time, she was then named the director of the CDC and served, I'd say, exceptionally, brilliantly during a challenging time in this country, health-wise, no other way to put it. But then after finishing her time at CDC, went to Merck and was initially recruited there to be the president of Merck Vaccines, and these days is executive vice president and chief officer of strategic communications, global public policy, and population health, a very big responsibility. Before she was at CDC, she was at UCSF at the time of the first beginning days of the HIV/AIDS epidemic, and it was a challenging time indeed. Heard her talk about it. Thanks for being here, Julie. Thank you. And Rob Youll is an attorney and a volunteer, a cancer survivor, who has for 25 years been a volunteer for the American Cancer Society and has served as a chairman of the board there, as well as chairman of the American Cancer Society's advocacy arm, ACS-CAN, which is a very effective group based in Washington, D.C. that we get to work with on a regular basis and truly enjoy the kind of strong leadership that ACS-CAN provides in D.C. and around the country. And I know you've just had some recent public opinion polling and reports released around that dovetail with some of the work that we do from year to year in commissioning polls that emphasize how much the American public really wants to put research to work, wants public health to be a higher priority, but it just keeps on not happening, either because, and this is speculation, our decision makers take it for granted, or people kind of give up and think, gee, these problems are too hard, we're never going to solve them. I don't really believe that second part so much. I think that people in this country want and expect highly trained and well-motivated people in any kind of research fields, and certainly in public health, to get to work as fast as possible. And that means there's got to be resources to support them and policies to support them, to have a higher priority for achieving health in this country. So these are people who bring different perspectives to those kinds of thoughts. And I'm going to start out by asking them a question, which is, if you had a few minutes to spend with the people who are helping draft the inauguration address for our next president, and the assignment is, I want to say something, the next president, want to say something about achieving better health in this nation, which is really a public health kind of goal. What should I say? How should I say it in a way that I can be proud of 4 years from now when I'm running again for another term, and that will really leave a legacy for this nation? It's a high stakes moment and a big opportunity, should we get it collectively, to build in language that will be inspirational for our nation, but that's also actionable. So what might go into those few thoughts that you're able to provide? And Julie, I'm going to start with you.
Well, you know, I thought a lot about this, and I think we all want to think of, you know, the moonshot for X, or, you know, a big promise in a particular area, and I thought of Alzheimer's disease, and clearly cancer is already on the radar screen. But both of our presidential candidates have said that they're interested in infrastructure. But I don't think they're thinking about health infrastructure when they're talking about that. And if we're going to go out and rebuild our roads and our bridges and, you know, our train tracks, I think it would be fantastic if they would leverage that investment and assure that they had health infrastructure embedded in those investments, so that we would, if we're building a road, we'll have a bike path. If we're building new schools, we'll have playgrounds and good nutrition in the schoolrooms, and that we really embed that health in all policy as part of the infrastructure portfolio that truly invests in the framework necessary to build healthier communities and a built environment that helps people make the right choices.
So that sounds a little bit like some of the things I've been hearing at this American Public Health Association meeting and otherwise about health in all policies. But it makes it specific, which I really like, about, you know,
well, it's risky because infrastructure is not something that really gets people's imaginations up and running. But I think if we really acknowledge that we're not on a sustainable trajectory in our nation, we can't afford to continue along the path that we're on. Maybe we can multi-purpose those infrastructure investments for better utility.
So, Rob, are you on board with that idea? Would you add something to it?
I guess what I would add to it is, if I had 15 minutes with...
We can't quite hear you. Do we have AV on Rob here?
Is this working now? Doesn't seem to be. Maybe I can borrow Julie's. How's that? Does that work?
Okay, well, we get it fixed here.
So if I had 15 minutes with the staffers who were taking the first cut at the State of the Union, I guess what I would talk about is what government is about. And when you go to law school, you learn a lot about that your first year. And basically what it comes down to is health, safety, and welfare. And I think the federal budget is an interesting proxy for what the values of this country are. We spend about 25% of the federal budget on welfare programs, broadly defined. We spend about 25% of the budget also on health programs, broadly defined. But interestingly enough, almost all of that, and it's a metaphor for our current healthcare system, almost all of that goes for treating disease. We spend less than 0.1% funding biomedical research. And my punchline, I guess, would be, there has never been a better time to make investments in that kind of infrastructure, because the promise right now for biomedical research is just enormous. And frankly, I think our priorities need to be readjusted slightly to really step on that a little bit more than we have. And I have a feeling you agree with me, Mary.
I'm nodding here, I'm nodding here. You know, that, I think, typically a new administration does talk about investments that can be made wisely, that will pay off, and for the most people possible. So, you know, the thinking about infrastructure, which both candidates have talked about doing something about, and adding in a health component, and it can be most certainly investing now so that it's less expensive later when we're paying for all those cancer treatments that we would hope had never been cancer diagnoses to begin with, et cetera. You know, it's a case we hope can be made. I'm liking this. How do you feel about this case, David? Or would you go a different direction?
Well, I don't think there's any disagreement on this panel about the importance of funding research or funding infrastructure that improves health. So I'll add a couple of comments. I think some of the research we desperately need is about the root causes of health problems. So we know very little about the social determinants of health and how to influence those in a way that promotes health at the population level. Our biomedical research enterprise focuses a lot on basic biological processes, and we're investing heavily in genomics and personalized medicine. And I'm not here to disparage that. I'm here to suggest that it would be useful to complement that with investments in prevention research and investment in research around the root causes of the major public health problems that face us and the solutions to those problems. And I think the infrastructure ideas that have been expressed are also very strong and positive. And I would add to that safe and affordable and healthy housing environments are very important. We have far too many people in our country who don't have a safe home to reside in. And we can talk with them about eating a healthy diet, and we can talk with them about substance use issues, and we can talk with them about physical activity. But if people don't have a healthy, safe, affordable place to reside, it's very difficult for them to act on the information that we try to convey. So I think some of the infrastructure that is needed even goes beyond the idea of having appropriate healthcare facilities and public health facilities and bike paths and walking lanes. It includes safe and affordable housing. The list goes on, but that's some of the things I would add to the comments that have been made.
Yeah, well, I would say that sounds like language one typically hears in an inauguration address. It's very soaring language about wanting for all of us in this country healthy, safe, affordable places to live and thrive. And, you know, those are right on target. You know, and they're taking action to get there with some examples. I don't know, it makes me think, Morgan, about all the work you're doing in nutrition. And yeah, you want to add
absolutely. I think it definitely helps when you talk about public health research, and I would agree that that is so important to keep funding that. And I think it helps to kind of have some tangible examples. So my salary is completely funded through an APHA grant through the USDA. So that was the Agriculture and Food Research Initiative established by Congress in the 2008 Farm Bill. And so the work that I do is working with low-income preschool centers in rural Colorado, working primarily with Head Start centers to help preschoolers to develop healthy eating habits, physical activity habits, programs to help them develop gross motor skills at an early age, and really kind of try to start some of those obesity prevention efforts as soon as you possibly can. Early childhood is a really critical juncture for that. I think a great example is some of those gross motor skills you develop at that age can actually predict your future physical activity levels. So a lot of these communities that we work with are really health disparate populations, and so the grant that I work on allows us to get out to those communities, do teacher trainings with the Head Start teachers, deliver programs, talk to families to figure out what their needs are, really work with the communities, and it's this grant and this kind of public health research that allows us to do that and deliver those programs to places that otherwise wouldn't really have access to any of these issues.
Isn't that fantastic? This is the story, not in the inauguration address, I would say, the inaugural address, but in the State of the Union message, where you're sitting in the balcony and the president turns to you and tells your story, and perhaps there's some of the kids you work with, you know, got the idea. It's the powerful story of what our young, highly talented public health workforce is doing to make a difference for us all. And yet we are choking off you and your colleagues' abilities over and over and over again by underinvesting. We're back to that word, underinvesting, but investing in a way that's going to pay off for more Americans, I think, is the theme you all are hearing. When I think about, do you know, I'll ask you, Margaret, do you know your elected representatives here in Colorado?
I do. I actually, a couple years ago, I was an intern for the Congressman Ed Perlmutter, who was a House representative from my congressional district.
That is fabulous and atypical. I'm going to ask the audience, this is participation time before you ask questions too. So sometimes I ask audiences, if you were in the local Starbucks on a weekend where you live, and your member of Congress was also in there, you're a member of Congress, on the same errand, getting whatever it is you like to order. Raise your hand if you recognize that person by sight. You can raise your hand. I expect this of the panel. That's pretty good. Okay, and now raise your hand if that member of Congress recognizes you by sight. 1, 2, a couple up here. Okay, this is a concrete goal that people working in the public health community can work to achieve. The first part, which you all probably, because you come to this session, you know, are already on top of. You know who represents you in the Congress, and I assume you've talked to those people, and I hope, hopefully regularly, but maybe not in person. So that second part of it is making sure that you connect personally and connect the dots, literally, between what you're doing to serve the public's interest and help them see how the dollars they're allocating and the policies they're formulating serve the public interest through you as an agent of better health, a better quality of life, of driving prosperity in this country. And it is typically the case that people in the public health community walk away from rather than toward that kind of responsibility and opportunity. So anything you can do in your home institutions to encourage more engagement that way will pay off. You know, in the words of former Congressman John Porter, the president of Research America, people in this audience, the public health community, can change the image of things to come, but you can't do it sitting on your hands. You know, it takes hundreds and thousands and tens of thousands of us to speak up, just as other interest groups, if you will, in our nation do. The thing that we have going for ours, the good news is that everybody's part of our, quote, interest group. The bad news is a lot of times we take it for granted that the truth will speak for itself and that good things will just continue to roll out and happen. But let me, I'm going to ask the panel another question or so, but I encourage you to have some thoughts in mind out there in the audience and step up to a microphone. There's one down there. There's also one over on that side. So I want to ask each of you to sort of draw on your experience recently, ideally, to talk about what have you learned about being an advocate, and what has influenced you when other people are trying to advocate to you. And I think of you, Julie, in that kind of role as when you were the head of the CDC, or in other positions, when people are trying to make a case to you. But then on the flip side, for everybody, when you're making the case to a policymaker, what have you found works best? And Rob, do you want to start out on that?
Mary, I think my experience, hopefully this is working, my experience is that it's all about stories, oddly enough. You go walk into a member of Congress's office, and you would think that they are all balled up and focused on public policy data. But really what they want to hear and what influences them is personal stories, preferably people who are their constituents, who have a heartfelt story to tell about why it is what they're advocating for can really make a difference in people's lives. I've seen it happen over and over and over, and it's extremely powerful. I would say the thing that has also struck me and is somewhat disappointing, although it's getting better and it's changing rapidly, is when members of Congress will tell you that they really support what you want, but that if they funded what you want, they'd have to fund all sorts of other things, and so they just can't do it.
How do you handle that?
Well, you politely and respectfully suggest to them that they were elected to exercise leadership, and the ultimate leadership is making policy and priority decisions and deciding what's most important among a number of important choices. It also helps to have the polling that you referred to to show, for example, that roughly 80% of Americans right now strongly believe, that we should make substantially greater investments in biomedical research. And if you have constituent-specific data, that helps even more.
Right, right. How is the polling data received?
Pretty well, and particularly with people who would otherwise be somewhat recalcitrant, it can give them a lot of cover. For example, we are a completely nonpartisan organization, but it's no surprise to know that traditionally over the last 10 years, we've had probably more difficulty persuading Republicans of the importance of increased federal funding for cancer research, for example, than Democrats. However, recently, some of the most conservative Republicans have jumped on board to fund biomedical research and cancer research, in part because they understand two things. Number one, their constituents want it, and number two, it's consistent with the idea of limited federal government. Because notwithstanding private philanthropy and companies like Merck that do great medical research, there's some research really that can and will only be funded by the federal government. And I think increasingly policymakers are starting to understand that.
Right. I certainly agree. I want to just reinforce a couple of points you made and see if others want to jump in on them, because we hear about it all the time. Depending on who's talking, saying that the Congress really, or let's put it this way, that Republicans really don't want to spend any more money on anything and won't fund research or prevention. Democrats will, and so forth. But there's so many markers of fact that demonstrate the opposite. They demonstrate that research and health are bipartisan issues, which seems to be a no-brainer. But look at, and we have, the names on the buildings at the National Institutes of Health. Right. They're both Democrats and Republicans, lots of them. And names on buildings at the CDC, Julie, are not all one party. So there's that, just as for starters, shows the history of strong legacy commitments. But the other part of what you're saying there, Rob, is that there are things that realistically only the government can do, for which there is no plan B. And a lot of that is very basic research, but also the kind of population health work that the CDC, of course, does in prevention. Julie, you want to chime in on that?
I agree with everything that we're saying about bipartisan and particularly about telling stories. I do think it depends on what part of our government you're talking about. The House is very different than the Senate. The administration is very different than the Congress. And then we should talk about state government, because that also is a very, very important and underutilized tool, especially for the whole public health system. But I think one of the things that I learned from some wise mentors was that everybody goes in hoping that somebody in Congress will solve their problem, meaning fund this, or give me this flexibility, or allow me to expand such and such a budget line. You have to really start with understanding what their problems are, believe it or not. It's much better to understand what is on the front burner of this particular congresswoman or congressman in their district, on their committees, on their plates, what's going on in their world that they need help with, and then thinking about, well, how can what my organization does or what my interest represents actually line up or support and reinforce what they're trying to accomplish? Because then you have a room of commonality. You have something you both share that you're both trying to accomplish. I think that gets you much further down the road than going in and just asking for something that you need. It takes a much more sophisticated preparation, and it doesn't always work because sometimes you can't find that. But to me, that's been the starting point for the most successful negotiations that I've had. I think the other principle is to go in a coalition, not as a single organization or a single entity. And we tend to overlook, and obviously my bias will show here, but we tend to overlook the importance of the business sector. Not just the biopharmaceutical business sector, but the broad business sector, because after all, employers still do insure many millions of Americans. They have a stake in how our health resources are being allocated. And as an employer, we do care deeply about the capacity to find cures and to create solutions rather than simply adding up the costs of chronic disease management and care. So really build a coalition that isn't just the choir preaching to the choir, but to bring in the broader set of aligned people. And they have money to invest and can sometimes be very, very helpful.
Boy, those are all, I would say, very important lessons to store away and put to work, even if it does mean doing a little more homework.
Yeah, it's a little more work.
It's worthwhile, rather than just have people talk to you politely and then do nothing. Right. So, David, what have you learned in your conversations with decision makers? And maybe if you want to touch on this great work for the transition team, you could tell us about that.
Well, I think I've learned many of the same lessons that you've already heard. The importance of stories to make things personal, to connect on that personal level. It's often said, no one cares how much you know until they know how much you care about a particular topic. And so it helps to establish that relationship. I trained as an epidemiologist as well as a physician, so I'm very comfortable with statistics, but they don't tend to move people into supporting a particular initiative. I think coalitions are also a very important aspect of what we do. I've done a lot of volunteering with the Heart Association. My work's been mostly in cardiovascular health promotion. And we go to the Hill and we talk about the importance of raising the investment in NIH broadly. We don't tend to talk about NHLBI specifically. We talk about NIH broadly and CDC and ARC. And that's because we've heard many times over the years that disease-specific requests for support are less well received than the kinds of requests for support broadly in biomedical research, including population health research. And when we talk with, especially the Senate, I agree, the Senate's so much different than the House. When you talk with people in the Senate, most senators have an academic health center in their state. And so they see investment in biomedical research as a good thing in and of itself, but also, frankly, as an economic stimulus to their state, because they're really wonderful jobs, of high-educated, well-compensated jobs that are created by investment in biomedical research. And so this argument can also help bring forward the discussion because it addresses an issue, an interest that the policymaker has, which is economic development in their constituency base. So I think tackling these things are all very important. The other document that you referred to, the document the Association of Schools and Programs of Public Health has put together, we have a legislative advocacy committee, as many similar associations have, and we spent some time over the past several months thinking about what we would want to communicate to the next transition teams, and we developed a document that lays out 4 broad goals that we would ask of the next president and Congress. And it starts with the idea that we embrace the APHA's idea that America should be the healthiest nation. We're far from the healthiest nation. There are many indicators that suggest we have a lot of work to do to achieve that goal. And there are 4 specific things that the association has adopted as things to promote. The first one is to afford all Americans the opportunity to have a healthy life through investment in population health promotion. Things like investing in public health programs at work, things like integration of primary care and public health to support population health improvement, which is already enshrined in the Affordable Care Act, but which needs additional support. And then also investing in the social determinants of health and health equity. Some of the things we've already talked about up here today: safe, affordable, healthy housing, education, agriculture policy that results in production of healthy foods so that people can actually achieve a healthy diet. Just as an aside, the Heart Association recommends eating 2 servings of fish a week. There's not enough fish currently being produced for everybody on the planet to eat 2 servings of fish a week. We have work to do from an agriculture policy. Fruit and vegetable consumption, there's not enough fruits and vegetables being produced for everyone on the planet to eat the recommended amount of fruits and vegetables every day. We have work to do in agriculture policy. A second area that the association's focused on is training the next generation of public health professionals, whether scientists or practitioners. We have great needs in both areas and relatively little opportunity to support training the workforce of the future. The third area is to invest in prevention research, and we've talked a lot about that already up here. Things like the cancer moonshot, very important. Things like investing in research on heart disease prevention, close to my heart, the nation's leading killer, the world's leading killer, and recent evidence is that improving trends are stagnating, perhaps due to obesity and diabetes, and we have more work to do in that area. Since I came to Colorado, I've learned a lot about the challenges of mental and behavioral health. That's another area of particular interest called out in the document for greater investment in research, though those are not the only areas. And the fourth area is for the United States to really restate leadership in global public health. We have a lot to learn from participating in global public health efforts. We also have things to contribute. And if we're going to lead and become a healthier nation, the kind of healthy nation we can be, these are the 4 things that our association has put out there as important messages for the next president and Congress.
And it's well worth, I'm going to promote it again, it's well worth taking a look at this document. So to get back to what you've learned about being an advocate, Morgan, maybe you can tell us, especially from the perspective of when you worked for your congressman, what worked and what didn't.
Yeah, absolutely. I would kind of echo a lot of what has been said already in terms of telling stories and really being able to kind of make that personal connection to someone. And then maybe just being able to highlight some of kind of, the unintended consequence or the unintended benefits of something, just really being able to highlight all the different things. So whether it is the economic aspect or whether it is that investing in public health will allow for the creation of more jobs, and then that can be beneficial. So just kind of trying to find those other ideas that may not be seen as immediate benefits, but really just kind of as many benefits as you can possibly tie into that one thing, just to see if one of those will stick. Because I think the more you can put out there, the more it is that there's one thing that will really click with that person, that's what's really important to them, and they will then feel motivated to act.
It's about raising the visibility too. If we raise aspirations and raise visibility, maybe we can get to, when I think of the phrase social determinants of health, I know I've used it in interviews, drive time radio all over the country kind of thing. It's one of the points that I sometimes try to bring in. And very often a moderator will say, wait a minute. I don't know what you're talking about. It's not a phrase that just falls off the tongue. People know what that is, social determinants of health. But maybe we could get there. Maybe a new administration could, by using that phrase or things around it that really people can relate to, that are quite meaningful, we can start to incorporate high expectations around making a difference around social determinants of health, so-called upstream efforts, as well as the actual treatment of disease and disability. Well, I want to see if there's anybody who would like to make a comment, ask a question. We've got some microphones. We want to make this more interactive if we can. On the other hand, you might want to wait a
While
moment.
they're waiting to come up to the microphone,
Please.
I just feel I want to pick up on something here, which you've said it twice: population health research. And I think not everyone appreciates that there's a growing science that's coming out of this emphasis on population health as it's defined in the Affordable Care Act, really talking about what is it that accounts for the difference in health status between populations. I'm an epidemiologist, and I study what are the determinants of health within a population. But there's a growing science around why are the people who live in this city with this socioeconomic status have such higher rates of heart disease than the people who live in a pretty comparable socioeconomically equivalent city who have much lower rates. What are the determinants at a population level? And that kind of population science is going to be so critical for understanding the determinants of health status and acting on them at the community or broader level. And yet the amount of money that we're investing in that kind of science is minuscule at best, absolutely minuscule. Most of it comes from foundations and enlightened philanthropists, but very little of it is coming from CDC, NIH, not because they don't believe it's important, but we just don't have the investment. I would really like to energize people around making sure that that domain of science is included in any portfolio of new investments that we might be able to generate, because it's critical.
Yeah, I hear you. I want to follow up on that and say, what do you think it will take to change that? Exhortations aside.
Well, I had a fantasy once, and I think APHA is taking this on with the Healthiest Nation initiative, which is to say, if I was the mayor of City A and I recognized that my health status was pretty bad, and my neighbor down the road, mayor of City B, had a much better health status, I'd want to know why. I'd be highly motivated to understand what do I need to do to bring my city up to a better standard of health. So I think measurement is really important, and we are beginning to do that through the various health metrics, but I think we need to make those more visible and more politically relevant. Right now, there's something that stays in the public health community and does not necessarily get broad play on the front page of the hometown newspaper. But just as there's a rivalry between football team A and football team B, or maybe I should say baseball team A and baseball team B, I think now we really need to create the expectation at the community level, well, why isn't my community better? Why does my community have lead in the water? We need to create awareness and then demand for improvement, and that will drive then the investment in understanding why and what to do about it.
So do you think, were you saying that the APHA might have a very big role in this?
I think so.
Yeah.
I really do. I love the campaign, or the concept of the healthiest nation. It's unconscionable that we're not, and I just think with this incredibly powerful coalition that if we really focus on it, I think we could do more faster.
Right. And you mentioned metrics too, of development. You mentioned metrics too.
The metrics, absolutely.
You know,
and to not shy away from them. You know,
right. Right.
it's okay if they're not great. Let's fix it.
Rob, you want to get into
I think
this?
Julie's point is really well taken. We have a phrase at ACS now where we're starting to understand that your zip code may be more important than your genetic code. And to put a finer line on that, I was looking at some data the other day. There is a zip code in inner city Chicago where the population has an average life expectancy 14 years less than a zip code 14 miles away. If you think about that, that is astonishing. And getting to the root cause of all that is really key. In addition to that, other kinds of what I would call non-traditional health research are just as important. When we, as an organization, got behind the Affordable Care Act, part of why we did it was our own, what we call intramural epidemiological research that showed, for example, that a woman diagnosed with breast cancer at stage 2 with health insurance, I'm sorry, I misspoke, without health insurance, had worse health outcomes and a higher mortality than women diagnosed at stage 3 with health insurance. Now think about that for a second.
Right.
I mean, if that doesn't convince you of the problems of health equity in this country, I'm not sure anything would.
And do you foresee that a new president, a new secretary of HHS, new senators, members of Congress can take on doing more for population health? Is there going to be a groundswell of willing advocates behind to assure that that person and others are going to succeed?
I hope so. My experience tells me, frankly, that NIH is less excited about that kind of research than maybe we would like them to be, but it takes advocacy to help move that.
Yeah, yeah. I sometimes think that there's a lot of awareness of what's right and would be best and should go forward, but then the daunting nature of trying to move the levers or figure it out, people fall off in their good intentions to be advocates rather quickly. So that's why it takes the American Cancer Society, with your track record of having made some hard decisions about advocacy and then gone for them. And I think more of us should get behind those efforts for sure.
There's the person at the microphone.
Julie. Oh, we're going to keep this. We want to bring you into this. Please tell us who you are and your question.
Good afternoon. My name is Flo-Jean Kofer. I am from California with the California Department of Public Health. And I have more of a philosophical sort of framework approach question. And it's this. You know, with the Citizens United ruling, we now have an unprecedented amount of money flowing into politics, not as if it wasn't there before, but it really has kind of opened the floodgates. And I think oftentimes in public health, we tend to think about problems from the perspective of how many people are impacted, what are the outcomes for populations, et cetera. I'm an epidemiologist by training, and that's sort of how I think, and I think it provides a very compelling case for why we should do certain things. But one of my aha sort of it's time to grow up moments was in having conversations with health insurers and learning from them that it wasn't really compelling to them to hear about how, how many people were going to be impacted. They were thinking about it from the perspective of how many customers are we going to get in? How much money are they going to spend with us? How do we keep you lifelong? And a good example of that was with contraception. I was thinking, it seems like it's much cheaper to pay for women's contraception pre-ACA than it would be to pay for a woman to have a baby and then baby visits and blah, 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 and all of this. And that wasn't their thinking. Their thinking was, well, people who have children are less likely to switch insurance companies, and that means now we have you as, a client for life, right? It's this very business sort of focused perspective. And so I'm wondering if you have thoughts and feelings on how we should be communicating messages from a business sense without losing out our primary sort of health is a human right framework in the process, right? Like, I don't want us to lose our humanity, but I also want us to be practical about how we engage.
You want to make sure we make a difference.
That's my open-ended question.
Thank you for that question. Does anybody have a thought? Yes.
Yeah, I'll take a couple of cracks at that, because there's a lot of really good stuff there to unpack. And, the first thing is that, we don't really have a good healthcare system in the United States. I guess I'm not surprising anybody by saying that in this room, right? We have 4 systems, not 1 system. And so I think it's challenging, and in the different systems, the incentives work differently. It'd be great if the next president, the next Congress were to adopt the idea of having single-payer universal health care. I'll put that out there. I mean, that's a personal opinion. I don't know that that's going to happen. In fact, I'm fairly skeptical that that's going to happen. So maybe what we should we should still strive to get it, I think. But payment reform could be helpful as a step along the path if we don't get single-payer universal health care, that we can drive the behavior of the health insurance industry through payment reform, risk-based contracting that puts an incentive in the health insurance industry for keeping populations healthy to begin with, I think would be a nice step. It doesn't get us where we ultimately want to go, but it's a nice step. So there's some initial thoughts, and there's probably other thoughts up here in other directions.
Okay, and I'm not going to respond to that. I want to make sure other people get in if you have a thought.
We're experiencing enormous upheaval right now in the industry. The insurance industry is being turned on its head. The pharmaceutical industry is turned on its head. The delivery system and the providers, everybody's undergoing extremely chaotic and confusing change at the moment. But the one thing that I think everyone agrees is that consumers are becoming much more engaged in the discussion and the decision process, and what they want is going to increasingly be an important driver of how any of this lands. So one of the things that worries me about that is that we don't live in a very health literate society. And so as we're thinking about what presidents could do in their new administration, I think we're missing the opportunity to think about the educational system and schools as probably a very critical component of health creation, because kids just are not prepared to understand, interpret, and make the health decisions that increasingly they will be taking on their own. I have a very educated family, and sometimes the conversations that go on in my family about health decisions shock me. It just completely flabbergasts me that these college-educated people would not understand some of the most foundational things. And so if that's happening in an environment where people are very literate overall, I just can't imagine how people with no background or no context. The fact is that somewhere around 40% of Americans don't know the difference between Medicare and Medicaid. And most Americans cannot tell you what a deductible is. Right. So we have a lot of opportunity to raise the bar.
Right. Not to mention the difference between a virus and a bacteria. Right. So I just came from a session in which there was discussion about the new National Academy of Medicine's Vital Directions essays, several reports, essays. And one of the points that Mike McGinnis was making when he spoke was with data showing how, compared to other nations, we underinvest so terribly in the early years of life, not only in the maternal and pre-delivery parts of prenatal parts of care, but then up into school too. And that's the point I think you're bringing out too. Well, everybody here would agree on. But to me, it's really striking in the context of our discussion this afternoon that it's about investing. What are the things worth investing in now that our economy isn't on the ropes? And I'm trying to get back inside the heads of a new president and administration and new Congress. What are we going to do now that's going to make a difference, a big difference for people? And when I think about what we could do with kids, my goodness, and that's what you're doing, right, Morgan?
Yes,
you want to say something about that?
Absolutely, yeah. I mean, I think that there's a lot of work both in terms of just kind of helping kids to learn more about healthy habits. So like the work I mentioned earlier in terms of helping kids to develop gross motor skills so they're more confident and do more physical activity, or they have less food neophobia so they're less afraid of trying new foods, so then they'll eat more as an adult. So things like that, and even just more education just in general in terms of nutrition. There's a lot of great programs going on in terms of school gardening that I think really kind of ties into a lot of the changes that really need to happen on a broader scale in terms of our food system. I think that that's something that could also be, definitely could be a priority in terms of, obviously we've talked, and you mentioned it earlier, it's definitely not supportive of healthy diets. And we know that health is at an early age, the diet can really be influencing chronic disease outcomes, whether that's in a preventive way or in a contributing to the development way. And then also just in terms of all the issues of food access and disparities, and I think that really influences kids as well, and that can kind of tie back into some of the infrastructure discussions we were having of improving just access to food, whether that's urban or rural or even within one city. I did my master's at Johns Hopkins in Baltimore, and the disparities in food access throughout the whole city were just remarkable. I worked on some interventions trying to improve food access in kids and in adolescents, and just even trying to get there to be a banana or a fresh piece of fruit in the corner store because that's the only store that's there. So really, I think that could have a big impact on kids, and then also just in general in terms of how do we transform the food system so it can be healthy for everyone, healthy for kids, and then more environmentally sustainable for the planet, because obviously right now it's not very environmentally sustainable. So making those investments now I think can lead to a lot of savings in the future.
So these are things that are cherished values, I would say, that we can all hold on to and support, even as we're trying to figure out what's going on in the turmoil and upheaval in our so-called health system, as you've brought out, in industry, in academia, in difficult times in many ways. And I think, not to mention the Affordable Care Act. Yes.
I'd like to follow up on something about kids, and then I also see we have someone at the microphone, so I'll keep it brief.
Thank you.
But there's some great programs that have shown promise that could be, I think, disseminated more widely. An example of that would be the Nurse-Family Partnership that has shown the ability to really improve the outcomes of births among women who are in the lower socioeconomic status. These are mostly teen mothers who are in low-income communities and who don't have good parenting skills because of our educational system that we've talked about. So the Nurse-Family Partnership sends nurses out to the home to work with these young mothers, the first-time mothers, and it's shown really wonderful outcomes in terms of keeping these young women in school so they graduate from high school and can potentially go on to college. Has shown great outcome data on the children so that the children are more likely to do well in school themselves and less likely to run into trouble with the criminal justice system. So these are programs that have been demonstrated to work, and we could ask a new president, a new Congress to disseminate this kind of program more widely. Investments in early childhood education, another thing that you mentioned, I think that's another idea that's been proven to reduce incarceration rates years down the road in the cohorts of children who have better access to high quality preschool. So I think there's a lot that we can do in this area, and it should be high quality preschool with good focus on physical activity and nutrition, the sorts of things you're mentioning. I think those could be critical and would be the easy thing to ask for. And
right.
We should be able to mobilize congressional support, political support around the health of our kids. If we can't do that, you know, it's going to be hard to do many of the other things that we're all agreeing on.
Right, indeed. And we do know that at least one of our presidential candidates has been emphasizing a lifelong commitment to children and parents. It's to children and health and just investing in our future. But it's not been easy to achieve that over the last several decades. We've really fallen off in states as well as nationally in that investment. So maybe really, just as we're having bridges fall down, collapse, you know, our educational system is falling down and collapsing. There's a lot of things going wrong, so it does seem like an opportunity moment to turn it around and make sure we're thinking about health in every step of the way. We want to take this question. Please give us your name.
Sure. I'm Kalpana Ramia. I'm from America's Essential Hospitals. So America's Essential Hospital is an association to make it easier, safety net hospitals. It used to be called National Association of Public Hospitals. So being a safety net hospital, the membership that we have takes care of vulnerable population. So you can already see my linkage towards population health discussion. Two pieces, one to co-sign with your suggestion that there needs to be a policy and payment alignment in the movement forward if we are going to push towards a population health in true sense. And also, I have a public health degree. I call APHA as my home, but I work in healthcare sector now, as in the association side. There's a movement of population health happening in both the groups. It'll be for you all up here in the leadership level and we all on the ground level to bring it together towards one health goal. Rather, there's a health care 3.0 movement going on. There's a public health 3.0 movement going on. It's talking about the same things. And me having been born and brought up in public health in some ways, now seeing the healthcare side, I just want to make a push moving forward in any situation. If we can force our own constituencies to talk to the other person that they're not used to, it would be very helpful.
Yes. So do you have some specific suggestions for how that might start happening more often?
Sure, I can give one specific suggestion which might be very much in line with what you guys are talking about, is this CHNA, Community Health Needs Assessment, right? Hospitals are supposed to do that, public health departments are supposed to do that, there is another needs assessment going on in the same community. If we can all pull together and do a needs assessment, one specific example, that might even bring everybody to the table. Mm-hmm. Yes, I'll be openly saying there has been turf war, and this is the time to even try to bring everybody to the table. That's one specific example. It's also, hospitals are being dinged for readmissions, for example. And they very well realize one of the key factors for readmission is homelessness, food insecurity. So they have a vested interest to work with in the social determinants of health side. So I'm just making a plug here to not lose a sector out there. Yes, there are different connotations in the past, but it's time to move forward.
Can I just build on that, Mary? Because
yes,
this has been a fascinating, I completely agree with this, this opportunity and the disconnect. And it's also an environment where in some communities extraordinary connections are occurring. Many health systems see population health as sort of population disease management. How can we take our population of diabetics and manage them with better outcomes and more cost effectiveness? But some health plans are moving into the domain that you've talked about, which is really getting into the community determinants of how people's outcomes are created and last. And as health systems begin to actually get out of the confines of the delivery facility and see what's really going on with their patients in the community and engage with community organizations and the public health department. Really amazing innovations are occurring. I could just use the example of Henry Ford Hospital in Detroit, or what I saw in Oregon at Oregon State University in the Oregon experiment. But in many, many, many communities now, there are these, I don't want to call them pilots because some of them are already having substantial impact, but incredible learning. Boston has a very interesting effort underway that's led through the health department. And in some cases, it's actually defining the role of that local health department a little bit differently than it's been traditionally defined. So as being the integrator and the coordinator of the community health needs assessment, helping to pull people together to set community priorities. Now, if we could just align incentives to reward people who contribute to the achievement of the community prioritized goals, then we would have a system and not a set of sectors. So I think that's kind of the dream. Can we align incentives as we go forward?
Yeah, I was thinking too about the absence of incentives. And Julie, do you or does anyone know about work that's being done to try to make that happen, to align? How do you get past the barriers to aligning those incentives?
Well, you mentioned a few minutes ago Dr. McGinnis at the Institute of Medicine and the projects that are going on there. There have been a number of fora and workshops focusing on population health and the intersection of public health and the delivery system. So I think they're tackling this and trying to identify ways in which the reimbursement system can more effectively align. And CMMI is obviously ideally situated to shape that for federal dollars. I think it's a little bit harder with insurers, but some plans, managed care organizations, they've already kind of figured this out. So lots of experimentation, and I don't want to sound Pollyannish, but I actually think that we could really get somewhere if we can just not get derailed by trying to take the system apart again and rather try to figure out how we can actually achieve the results that we're looking for, which is ultimately better health and affordable care.
Should we take another question? Is everybody okay? Okay.
Hi, just piggybacking off of her question actually, because it sounds that
Could you speak up just a little bit?
Can you hear me now? All right, just piggybacking off of her question, it sounds like there's a lot of local and state policies and a little bit local communities that have been developing and solving some of these public health issues. Do you think, how do you see, should there be more of a federal government role in maybe implementing these kind of policies countrywide, or do you think a better way of implementing and helping public health would be from the state and local government?
There's an easy question.
Well, I'm not really a public health person.
It's a disclaimer.
Yes, you are.
But let me tell you, I tend to think about things a little bit differently. And the question I always ask myself is not so much what would be better, but what's achievable. And right now, my experience tells me that you've got to be pretty careful, given the current political climate of the country, and particularly in the House, about trying to move more and more things to the federal government. I think as a big picture idea, that's probably a non-starter. So I hope you're not offended by my pragmatism, but there's a lot that can be done at the state and local level, and you don't tend to fight that philosophical battle, which frankly I don't think you should underestimate.
I completely agree. That's why I kind of asked that question, because I think from my understanding of public health, I think, especially from what I've learned, it seems that a lot of the solutions that I've been taught have been at a federal level. But I think there should be, I think state and local government can have, it's much easier to do it at a state and local government versus at a federal government.
Yeah, I mean, our experience, take tobacco control as a great example. We work at both levels. The last excise tax that went through at the federal level, we were a big player. Last week, we sued the FDA to require them to implement the express congressional mandate of graphic warnings on cigarette packs. Working with the federal government has the advantage that you only have to do it once if you're successful, right? So why is it that we're spending so much of our energy at the state level? It's because, frankly, we've got, I think, 16 tobacco tax initiatives going to the ballot next week or actually the week after. That's a lot of resources. There's one in this state going on right now that would increase tobacco taxes by $1.75 a pack. You would think that we would be spending all our resources on that ballot initiative, right? We're not. We support it, but there are many, many others that, frankly, the polling tells us have a much, much better chance of prevailing. And the population in this state is roughly, I think, 2%, 3% of the national total. You know, if we can spend $5 million on a tobacco tax initiative in California with a good chance to win, that's where we're going.
It's practical.
And that's where we do go.
Right.
And part of it, I can't recall where you're from, but we had someone from California before. Californian tobacco tax and tobacco legislation and public policy is always the leader. So if we can get something done in California, it has a lot of benefit over and above just what happens within that state.
Yeah, and I'm like right now in New York, and so New York City has.
Well, there you go. You know, same thing there.
Yeah, has one of the highest tobacco taxes in the country. So yeah.
So I'll chime in and make a plug for Colorado since I live here. And we think we're going to get that tobacco tax passed. Even if we don't, we're consuming $17 million of Philip Morris's money in opposition. So we're at least taking a bite out of their opportunity cost to wage their battle in other places. But I think we are going to get that. I think we are going to get it passed. But if you've been in Colorado very long, you will have seen the advertisements on television or heard them on the radio that is opposing the amendment to raise the tobacco tax. We haven't raised our tax here for 12 years. We've gone down from about the middle of the pack in terms of taxes to about 38th across all states. I think we have a reasonable shot of getting it passed. There's over 100 organizations in the state that are focusing on this, including Children's Hospital, the university, the Heart Association, the Lung Society. So I think there's a lot of support behind it. And it underscores the importance of working at the state and local level in addition to working at the federal level where that's appropriate. One of the other things that I've heard people talk about, and Julie, I think you talked about this, was the idea that local health departments and healthcare systems work together on community health needs assessments. Also, one of the earlier people in the audience had a question about this. And that's another great example where state and local efforts can be very helpful, but it has been promoted by the Affordable Care Act, which is also important federal legislation, such that the community health benefit for nonprofit hospitals goes into community health needs assessment and population health improvement programming, and partnerships with local health agencies, local public health, can be an important part of that. It's not required, but it can be facilitated through investments at the state and local level and getting local public health agencies involved with the healthcare systems in their jurisdictions. So I think this idea of multiplying the effectiveness of federal legislation by reinforcing it through state and local action can be very effective.
I think I would also add that much of what happens outside of the typical healthcare delivery happens through NGOs, and they operate really effectively at the local level. Sometimes what's missing is a coordinating function to try to, first of all, understand what is the universe of entities and who's doing what. So they're not always organized in an efficient way, but as a lot of communities where the NGOs came together to participate in the community needs assessment, there was kind of a reinvention of the self-organization and much better understanding of who was doing what and where the gaps were. So I think that's a really, really important force of health that is not going to be fixed by federal legislation. It can only really happen through you know, the universe of what's already going on locally and is doing so much of the out of healthcare system care. And you know, when you look at the OECD countries in terms of proportion of GDP on healthcare, obviously the United States is the outlier. But if you look at OECD countries in terms of healthcare investment plus social service investment, we're an outlier there too, because we spend the least on social services. Yeah. And we're dependent on this volunteer philanthropy to really fill in those gaps. And I think it's an incredible part of our system, and I can't imagine that it could be organized anywhere other than at the local level.
And do you think, Julie, in your observation, that we're at all moving in the right direction that way? And I hope so. I mean, we talk about problems a lot, but actually we've made a lot of wonderful contributions, you all and your colleagues, in public health over the decades. But we just aren't where we want to be. There's no question about it. And trying to figure out where the barriers are and how we move it and use things that we didn't have 20 years ago, and you know, incredible communications capability to coordinate better in a community or more broadly. I think my opinion is that our policymakers are not as eager to learn from what might be happening in other countries as others, you know, as we might hope, because there's some pretty powerful messages there. Leaving aside for a moment those with single-payer health systems that are, you know, very difficult for some people to look at. But in terms of other social and health systems, you grimace. Do you agree that they're not looking, Julie? They aren't willing to look, or is it, do you have any ideas about opening up eyes?
Let's just talk about, you know, parenting and how difficult it is in this country to get really equitable parental leave when babies are born or children are adopted or fostered. That, you know, we are way behind most of Europe in the amount of time that we allow parents to spend with their children in those earliest days of their lives. And that's just a statement about what do we really value in our country. And I think we don't have to look very far to see how some of our traditions really shortchange getting kids off to a healthy start.
Yeah, it's back to that underinvesting early in life as a value. So.
It's a value.
Yeah.
You know, there's another point I think that we should talk about here, and Julie alluded to it when she talked about the business community. If I could do one thing to improve investment in public health, I would have the economy grow by 5% per year.
Yeah, yeah.
Because if you take a look at what happens to private philanthropy, to government investment, to companies like Merck, and how much money is being spent, how many resources are being spent to improve public health, it's all a function of how many resources we have to start with.
It's true.
Yeah, you actually took a question, answered a question I was going to ask as we get closer to wrapping up is, you know, what one thing, or two things are okay, might you do if you were part of the administration, let's say, and thinking about how to make a difference here to improve public health. So you've mentioned, Rob, let's figure out how to grow the economy. And by putting health, we talked about this when we started off. If that's going to be about infrastructure, maybe you're thinking of other things too.
Well, I think the point is it can be synergistic.
Yes.
You know, if the economy is growing and we continue to make investments, wise investments in public health, that in turn will have a huge effect on economic growth in the future. Yes. To mention nothing of the collateral benefits just in terms of quality of life.
Right. So it's making smart investments all the way around. And it gets back to that earlier theme. So what, the rest of you, what one or two things do you think should happen now or soon to really make a difference in public health? Morgan, do you have an idea on that score?
Yeah, I would say probably just kind of some of the discussions we've been having is really investing in trying to fix some of the underlying social and environmental determinants of health. I think that's kind of what's really going to have the biggest impact in the long term. So whether that's trying to make improvements in the food system through food access, or making there be better housing or better neighborhoods so kids actually can feel safe to go outside and run around and play. And just kind of having access to all of those things around your built environment that you need to be able to live a healthy life and have access to that is so really investing in trying to promote more health equity and kind of eliminating some of those health disparities that come along with environmental and social differences. I think that's kind of the most important thing that can kind of have the biggest tangible impact in the long run.
So I imagine the APHA advocating for that. Can you think of other groups, including communities, that would rise up to advocate? Because it is typically the public's demand that ultimately moves the Congress.
Absolutely. I think kind of nonprofit groups coming together, NGOs. I think a good local example in terms of the food system is there's a lot of, maybe hasn't been a lot of work on a national level, but then there's been a lot of really great work happening on a local level. There's been a lot of local food policy councils that are kind of coalition organizations that have sprung up across the country. I went to some of the Denver Food Policy Council meetings just as an interested community member, and so I think kind of some of those organizations that kind of some of the things that were addressed earlier, that coalition building and to kind of come together on some of those issues and to have more power to advocate for, here's the work that we're doing, here's how well it's working, we should try to make these changes on a broader scale.
Right. Sounds like they need a megaphone.
Yes,
we should all
that would be
hearing
really
more
helpful.
About that would be good. David, do you have some thoughts in this regard?
I certainly agree with what Morgan said. I think these are really important issues. I would add to that investing in education. You know, and it piggybacks on what Rob was saying a minute ago as well. We speak of a virtuous cycle where a well-educated workforce is going to be a productive workforce and contribute to community prosperity and business productivity. And that generates economic revenue that you can invest in the education sector as well as housing and agriculture and other social determinants of health, so you can get this virtuous cycle going. And if you think about where to invest to get it started, education is not a bad place to have that investment start so that you have a well-educated workforce from a well-educated community leading to economic prosperity.
Julie?
Well, this is hard. We've talked about business, we've talked about education, talked about how to leverage the ACA and the accountable care organizations, for example, more effectively. You know, where's the leadership? And this is the question that comes to my mind. There are a lot of leaders, but at a national level, a visible, empowered leader to pull all this together into a domestic policy agenda that really has teeth and clout within the administration and credibility within the Congress it takes a certain kind of leader. And no offense to any of the existing or past leaders, I just think this is a really big deal, and if we don't get that right, the chances of really being able to create a health movement is probably slim to none. So it's important that whoever is the next president of the United States chooses, not just a Secretary of Health or agency heads, but really gives thought. I'm not advocating a czar of health, but I do think we need to really think who's going to have the accountability for making sure this really gets pulled together and happens, because it is really a health and all policy effort. It isn't one cabinet or one agency. This is really about a whole of government and a whole of citizenry opportunity, and leadership is going to be everything.
Well, I certainly agree with that, with what we've all been saying here. But simple things, even when we get on the other side of the election, of of spreading the word among all the various networks we touch as individuals or organizations. Keep asking that question in the days between the election and then the inauguration. Let's be sure that as leaders are selected, as systems are put in place, councils are formed, that there is going to be health in all policies. And all use that same phraseology and going deeper if we're trying to make a particular point, but staying on that high road so it just becomes heard over and over and over again, whether it's on social media, in every tweet you send, and I'm trying to send more, I'm working on that, in regular, I should say, old-style publications that are high influence, nonetheless. In every state in this country, people who are in public policy read letters to the editors, read editorials, and pushing constantly for our hope and expectation that we're going to have health in all policies, and then it can go into the details on that so that we get action instead of disappointment and hand-wringing going forward. So we're going to wrap up here. I want to mention something which is an opportunity, an additional opportunity other than speaking out when we get the identification of new leadership. But on the Monday before Thanksgiving, coming right up, it's always Public Health Thank You Day. Public Health Thank You Day. So it's a chance to say thank you to individuals that you know at all levels of their career and positions they might be in. Research America has sponsored this for many years now, and you can get to it, social media, hashtag PHTYD. Did I say that right, Suzanne? Yeah. And also via our website. And I really believe that, and this is a program that started in Australia that really helped raise the awareness, including political awareness, of the value of the public health community. And if thousands and thousands, and at some point millions and millions of Americans are thanking people they know or paying attention to the fact that so many people are being thanked for their efforts in public health, on that one day, doesn't cost anything, Public Health Thank You Day, Monday before Thanksgiving. Be a part of it. Give us a quote we can use in addition. So please join me in thanking this terrific group of people for taking time to talk this afternoon about making a difference for public health in the next administration and the next Congress. Thank you.
Thank you.